Afternoon, folks. This is part two of my lesson on the human urinary system for anatomy and physiology. If you have not yet watched part one, I strongly recommend you go check that out first so that you have the necessary background information needed for this section. If you are one of my students, you should probably also go on my Blackboard site and get a copy of the handout attached to the urinary system so that you have some crucial background information and spellings of the terminology. I'll try to give spellings throughout. And I also recommend you might want to have your textbooks open if you have them handy so that you have some diagrams to consult as part of the things that I'm discussing. As always, I will not be giving homework assignments or other things in this lesson. This is strictly going to be just the content. Now, last time we talked, I was discussing the basic structure and function of the urinary system. We looked at all the organs along the urinary tract, discussed the filtration of blood and the formation of urine, the movement of urine through the urinary tract, and we talked about hormonal regulation of urine production and body fluid levels. For this lesson, I want to focus more on the physiological side of things. We're starting to get into that with the hormones, but now let's talk a little bit more about functions of the urinary system, including some that have nothing to do with urine itself, or very little anyway. So let's begin with micturition. micturition. Micturition is the formal term for what you probably think of as urination, the emptying of the urinary bladder. Now, the micturition reflex is one of our basic reflex actions. The body can do this even if you are comatose or brain dead. It's activated by the stretching of the bladder walls. There are stretch receptors found in the walls of the urinary bladder. Increased pressure from urine contents will stimulate those receptors as the bladder fills up more and more with urine. You might recall I said last time, once you get above about 300 milliliters of urine in there, the pressure inside begins to rise rapidly, and you become increasingly aware of a need to urinate. Now, parasympathetic signals are going to go to the spinal cord. Your brain doesn't actually have to be functioning for you to urinate. The spinal cord is totally capable of managing this for itself. It's one of several reflex actions that the spinal cord basically makes the decisions about. Now, under normal circumstances, there's a baseline tonic contraction, as we call it, a baseline level of contracted tension maintained in the external urethral sphincter. So whenever signals arrive at the spinal cord, that in turn stimulates and says, hey, open up that sphincter so that urine can pass through. Pretty simple reflex arc. Bladder walls get stretched. Parasympathetic signal goes to the spinal cord. Spinal cord says, okay, let's relax the external urethral sphincter, and urine flows. Now, interesting thing about this is that unlike most reflex actions, this is one we can consciously control. We can choose when to urinate or not to urinate. Now, this basically means that we are able to override regulation of that sphincter. It is a skeletal muscle sphincter. You do have conscious control over it. Now, of course, when you're a baby, you don't know how to do this. Babies just pee whenever they're going to pee. Now, as you get older, you learn to manage that. You gain the ability to inhibit micturition, to control when that sphincter opens or does not open. In most normal humans, this develops about the ages of 2 to 3 years old. By the time you're 3 years old, you can probably choose when you urinate and when you don't. Now, the thing about this is that you get that signal not only to the spinal cord, you get a spinal cord signal that says relax the sphincter, you also get a signal going to the brain that makes you consciously aware of the need to urinate. And you can say, this is not a good time. I'm in class right now. I'm on a date right now. I am nowhere near a place where I should be urinating. Let's not do that at the moment. But you can only maintain this for so long. As all of you know, whenever you've had to hold on for a little while you were in a moving car or otherwise not near a bathroom, the longer you wait, the more the pressure grows and the more intense the need to urinate will become. Eventually, that need will overcome your personal failure to avoid the urine, and your brain will say, heck with it, we're just going to go. At some point, you will urinate. Now, holding it in, as we put it, for long periods of time is not advisable. The more commonly you do that, the more it can interfere with the reflex arc, make it more difficult to manage urination when you need to. It can put strain on the bladder, especially if you've got backup into the kidneys, because more urine is coming in as the bladder is filling up. Overall, long-term consequences of frequently holding your urine can lead to damage to the kidneys and can lead to greater likelihood of urinary incontinence as you age. So it's my strong recommendation you try not to hold that reflex any more than you need to. Thing or two to know here. Sometimes circumstances will make it harder to hold in. Anything that causes a sudden loss of tonic control can result in urination, even if that's just a small amount of urination very quickly. When you are frightened, that can sometimes result in a loss of tonic control that can result in urination. When you are suddenly startled, that can happen. Sometimes whenever you cough or sneeze, that can happen. The likelihood of that occurring as you get older tends to go up and up. Also, the more pressure there is on the urinary bladder itself, the harder it becomes to resist the need to urinate. If you're wearing very tight clothing, that can put pressure on the bladder. If you're sitting in certain postures, that can put pressure on the bladder. Now, it's a common myth that women have smaller bladders than men. That is not true. What is true is that the orientation of the female bladder further forward in the pubic cavity in front of the vagina means that the female bladder is often under more external pressure than the male bladder. And that means that there is growing awareness of the need to urinate. Furthermore, when a woman is pregnant, swelling of the abdomen puts pressure on the bladder, and that means that the female bladder can hold less urine whenever a woman is pregnant, and that therefore accounts for the increased frequent need for urination that is so commonly a feature during pregnancy. All right. Now, I should point out that sometimes the response to urinate will be stimulated by things other than pressure. If the lining of the bladder or the urethra becomes irritated, that can stimulate the sensation of the need to urinate even when there is no urine present. This is particularly a problem if you have a urinary tract infection. If you've ever had one, you know how it feels, that you feel like you need to pee, but you just can't because there isn't enough urine in there to do so. That need is, again, being stimulated not by the presence of urine in the urinary tract, but rather by irritation of the bladder, setting off that reflex arc. All right? By the way, you don't have to answer this. You're not gonna because you're not with me right now. But are you feeling the need to urinate right now? Yep, probably, because I've been talking about it. Whenever you are thinking about this, whenever you're talking about it, it stimulates awareness of the fullness of your bladder. And that means that you are more cognizant of any pressure that is already present there. And therefore, you begin to say, hey, maybe I need to pee after all. So there's a strong psychological factor in all of this. You all know that if you are trying to hold it in, having somebody talk about dripping pipes or flowing waterfalls or flowing hoses is not the thing you want to hear at that moment. All right? Sound good? Okay. Now, the production of urine is just one of several functions of the urinary system. And you've already seen that we have blood pressure regulation as part of this. But let's talk for a moment about your bodily fluids as a whole. A big part of what the urinary system is doing is not just passing out wastes. It is regulating the overall fluid levels of your body. Total fluid level matters for a lot of purposes. It affects blood volume and thereby blood pressure. It affects your concentrations of electrolytes. It affects the pH of your bodily fluids. There are several control mechanisms for regulating your levels of bodily fluids, some endocrine, some nervous in nature. And I should point out this is not the only system that does so. Your respiratory system excretes a certain amount of water, breathe out, and you're breathing out some water vapor. Kind of huff your hand. Feel the moisture that formed on your hand right there? That's because you've got vapor in your breath. You can see it most clearly when it's cold out and your breath mists. Condensation. Skin plays a role in this. Whenever you sweat, you're passing a certain amount of water out of your skin that way and a little bit of electrolytes along with it. So the integumentary system has a role in this. And finally, the digestive system has a role in this. The digestive system does pass a small amount of fluid out along with solid feces, although that's not its chief function. The digestive tract is much more about recapturing water than it is about releasing it. Now, you have all heard the statistic, I am sure, that the human body is like 90% water. Nowhere close. Now, the actual percentage of water in your body is probably going to be somewhere between 60 and 50% of your total weight. So 50 to 60% of your total weight is water weight. On average, for men, it is closer to 60%. For women, closer to 50%. The bodies of men, on average, store about 8 to 10% more water than the bodies of women. A big part of the reason for that is because a higher percentage of female body weight is in the form of adipose tissue. That women have a higher body percentage of fat than men do on average, and as a consequence, a greater percentage of the female body's total mass is fat volume. Now, we can take a look at your water fluid compartments. Where's the water found in you? 60 to 50% of you is water. Where is it? It's in a couple different places. We can talk about intracellular compartments versus extracellular compartments. Now, about 2/3 of your body's total water is found in intracellular compartments. That is, it's found inside of your cells. It's making up part of the cytoplasm of the cells. 2/3 of your water is inside of your cells. The remaining 1/3 or so of your body's water is found in extracellular fluid compartments. About 1/3 of your body's water overall. Where is this extracellular fluid we keep talking about? Blood plasma, some of it. Interstitial fluid within tissues, tissue fluid between cells is part of it. Your lymphatic fluids, lymph is an example of an extracellular fluid where some water can be found. The humors inside of your eyes, the vitreous and aqueous humors, contain water volume. The cerebrospinal fluid that surrounds your brain and spinal cord has water volume. The synovial fluid found in your joints is part of this. And a variety of serous fluids in body cavities and mucus fluids lining body passageways. All of these contain a certain amount of our body's water content, to say nothing of glandular secretions, in which hormones are often released with a little bit of water. Now, depending on what substance we are dealing with, the overall levels of electrolytes in our fluid are going to vary. Not all bodily fluids have the same composition. But in general, when we are looking at intracellular fluids, we will find that intracellular fluids are typically higher than extracellular fluids in potassium, magnesium, phosphates, and sulfates. Those things are usually higher concentration inside of cells than outside of them. Extracellular fluids are typically high in sodium, calcium, chlorine, and bicarbonate as compared to intracellular fluids. And vice versa, of course. So you're going to find that the intracellular compartments tend to be low calcium, low sodium, where the extracellular compartments tends to be low potassium, low magnesium, and so forth. Now, movement of these ions across membranes is regulated in a variety of ways that you all learned about back in Bio 1. Some of it is regulated by diffusion from high concentration to low concentration areas. Some of it is regulated by active transport mechanisms like the sodium-potassium pump found on either side of the membrane. And you're going to find that your body in general is going to move electrolytes around as needed to maintain the desired concentrations. So if we're finding that the concentration of potassium inside of a cell is low, it's going to tend to take in potassium from the outside. Likewise, if extracellular calcium levels are low, the body's going to try to release calcium into the extracellular fluid. Wide variety of transport mechanisms to do that. We are not going to recapitulate those transport mechanisms here. Presumably you learned about cellular transport mechanisms way back when you took your bio classes. But if anybody's got questions, let me know. But we can't talk about the electrolytes and what they're doing unless we first talk about the water that contains them. So let's talk a little bit about regulating water levels in the body. How do we keep the water level where it needs to be? Because it's possible to have both too much and too little water. Too little water, effects are obvious. Dehydration is a significant problem. Blood pressure drops, cells begin to plasmolyze, concentrations of both wastes and electrolytes go up, and eventually dehydration can kill you. You'll die of dehydration long before you die of hunger. Getting thirsty? There's a reason for that. Let's talk about water input. Now, the total volume of water in your body, barring unusual circumstances and assuming you're being properly fed and hydrated, stays pretty constant. And the total water needs of the average human, pretty consistent too. Average healthy adult human living in a temperate climate and engaged in normal levels of activity needs somewhere between 1.5 and 3 liters of water per day. Just about 2 liters of water per day does it for most of us. Now, about 90% of the water that your body requires is taken in from outside. You drink it or it comes in along with your food. About 10% of your water needs are actually met as a byproduct of metabolism. You might recall that a lot of metabolic processes in our body, particularly dehydration synthesis reactions to make organic molecules, actually produce molecules of water as byproducts. Likewise, aerobic respiration, ATP synthesis, makes water molecules as one of its byproducts. So your body actually supplies about 10% of its own water. Some water does come in to you, well, it does form within you, and that water can be repurposed to meet biological needs. But about 90% of your water has to come from outside of your body. So there's only really one way to handle this. The only real way to deal with water regulation is to take in water in that regard. You've got to have a mechanism to get it into the body, take it in with your food, or you drink it. Now, the sensation of thirst is our body's management technique to basically tell you, hey, you need to take in some water. Thirst is responsive to a couple of things. Primarily, it is responsive to osmoreceptors located in the hypothalamus of the brain. The hypothalamus contains a region called the thirst center. The thirst center monitors the osmolarity of your bodily fluids. Osmoreceptors there can track when you need more water coming in. They, in turn, then stimulate the sensation of thirst, the desire to consume liquids. Now, this is not only triggered by osmoreceptors, it is also triggered by habit and by social environments. If you are accustomed to always having a drink of water right before bed or first thing when you get up in the morning, you are going to habitually feel thirsty about that time. If you are accustomed to finishing class and getting a drink of water before you head to your next class, you'll probably feel thirsty right around then. You normally start to feel some thirst right around meal times if you're used to having a drink with dinner. So we have a certain amount of social conditioning that goes into the thirst response as well. We've also found that stimulus in which we are looking at dry environments can stimulate thirst. You'll get thirstier, of course, whenever you're in a dry environment. You're traveling in the desert, you're going to shed water more rapidly. But we found even if you're watching videos of a desert, you will get thirstier. If you're watching Star Wars and seeing the parts of Star Wars that take place on the desert planets Tatooine or Jakku, then yeah, you're going to find you get more thirsty while you're watching them than if you were watching something set in the wet swamps of Dagobah. So yeah, a lot of psychology involved in thirst. But one way or another, you do need about 1.5 to 3 liters of water a day. You don't get it, you're going to have problems. Now, when you drink, the thirst sensation tends to go away pretty rapidly. Take a big chug of water, you don't feel thirsty anymore, right? That water has not been made available to your body yet. It takes time. You drink that water, it still has to be absorbed by your digestive tract before your body can make use of it. But The thirst receptors are responsive to moistening of the oral mucosa, the mucous membrane inside of your mouth, and they're also sensitive to stretching of the GI tract. Those signals basically tell the hypothalamus, okay, some water came in. You're good now. Is it possible to have too much water? Yeah, not easy. It is hard to end up with too much water. Most of us are chronically dehydrated, folks. The overwhelming majority of Americans are not getting the full amount of water they need every day. Dehydration is the single #1 cause of headaches and workplace fatigue. See, talking about water, kept a full glass next to me for this lecture, knew I was going to need it. Now, technically, you can overconsume water. It's hard to do. I wouldn't get an extra glass of water and say to myself, oh crap, am I taking in too much? Probably not. Unless you're taking in like a gallon of water in an hour. Odds are pretty good you are not going to end up with water toxicity. It can happen, but highly unlikely. So I'd say, when in doubt, have another glass of water. You probably need it. So, how about water output? This is a thing that has a few more control mechanisms involved. There are several different ways that we manage water output. Taking in, only real way to handle that is to find some water and drink it. However, releasing it, our body can control to a certain extent how much water goes out at a given time. Sometimes you'll want to release more than others. Now, in terms of water loss, there are 3 basic mechanisms for getting water out of the body. About 61% of the water your body passes out leaves via the urine. About 35% happens via evaporation from the skin. And about 5%, 4 to 5%, goes out along with your feces. Now, that's the minor component right there. That about 4-ish% of water that leaves your body is coming through the GI tract. The colon, in particular, is really good at reabsorbing moisture from the GI tract. As food passes through your intestines and your stomach, lots of watery solutions there to break it down and digest it. But once that's finished, the colon reabsorbs most of that water before the feces pass out of the body. A small amount of moisture remains in the feces. You lose about 4% of water that way. Now, if the colon is irritated, you can end up experiencing diarrhea, in which your body passes out excessive amounts of water because colic reabsorption is impaired. We'll talk about that more when we discuss the digestive system. How about that 35% that's going out through the skin? Well, you sweat. Water is released onto the surface of your body. Water evaporates away, goes away. That is a significant part of how our bodies regulate their temperatures. One of the reasons water is such a useful substance for life is because living things can shed water to shed heat. Water stores heat really, really well, and therefore evaporative cooling is a very important mechanism for eliminating heat as well as excess water. Even on a cold day, you're still sweating. You just may not notice it, because at all times your body is producing a tiny amount of sweat that we call insensible perspiration, because it's being released in such tiny amounts that you're not even consciously aware of it. That insensible perspiration sheds some excess water. It sheds a little bit of nitrogenous waste. We shed some ammonia and some urea that way, little tiny bit of sodium as well. But for the most part, it's just dumping heat along with the water. Even on a cold day, you make about 500 milliliters, about half a liter of insensible perspiration. Now, as the temperature begins to climb, that number is going to go up and up. In general, you will find the approximate ratio is that for every degree Celsius by which your body temperature goes up, the amount of perspiration rises by about 100 to 150 milliliters. Now, in hot environments, your body needs to cool off more rapidly, you sweat more. That is sensible perspiration, sometimes called diaphoresis. D-I-A-P-H-O-R-E-I-S-I-S. No, wait, second I is not supposed to be there. It's E-S-I-S. My bad. Now, on a hot day, when you're working outside in the heat and getting lots of sun, you can shed water really quickly. Working outside in the heat, you can dump as much as 8 to 10 liters of water every single day. Needless to say, maintaining water intake under those circumstances is super important. If your body cannot properly compensate for water loss, blood pressure is going to drop, you can run the risk of passing out, and if your body can no longer effectively regulate its temperature because you don't have enough water left to do that, heat stroke and heat exhaustion become very real dangers. You're especially in trouble if it's a hot day and you stop sweating. Because if you're still out in the heat, you still feel hot, and you're not sweating anymore, that means your body can no longer spare the excess water for doing that, and you need to go cool down quickly. Now, you get hot, you're sweating a lot, your natural inclination is going to be to drink a bunch of water, right? Makes sense. But water alone isn't going to cut it. Because if you're just replacing lost water, you run the risk of diluting your body's electrolytes, unless you're taking them into account too. So let's talk about this for a minute. Let's talk about the osmolarity of your bodily fluids. That is, what concentration of electrolytes do we need relative to fluid volume? Now, human osmolarity for our extracellular fluids, intracellular fluids depends on the compartment. Some cells need different concentrations of stuff than others. But overall, your body's extracellular fluids typically maintain an osmolarity of averaging about 300 milliosmoles per liter of bodily fluid. Normal functional range for most people is about 290 to 310, so averaging right around 300 milliosmoles per liter. Milliosmol, that is the unit for osmolarity, standard unit that we employ. If you're abbreviating that, that is lowercase m, capital O, lowercase s, lowercase m. So M-O-S-M. Hold on 1 second, folks. All right, yeah, so milliosmol is the standard unit of osmolarity, lowercase m, capital O, little s, little m, / L for liters. So about 300 milliosmoles per liter is the standard osmolarity of your extracellular fluids. Now, osmolarity changes can trigger a bunch of different responses. If your osmolarity drops, that is the total concentration of solutes goes down relative to the volume of water, that will trigger the body to start shedding some water. That's going to say, okay, we need to get rid of some fluid volume here, right? We need to reduce the fluid volume by way of increasing the concentration of solutes. So you'll find that that will often lead to the suppression of ADH, so that your body releases more urine, and it's going to stimulate or shut down thirst responses. By contrast, if you have a rising osmolarity, body says, okay, we want more water volume. So that's going to basically stimulate the production of ADH so that you retain higher volume of water. It's going to stimulate the thirst reflex so that you take in more water. Now, whenever this happens, whenever your body's trying to retain water, the kidneys will reabsorb more from the filtrates. Aldosterone is going to help with that. Now, if you have osmolarity dropping, thirst will be inhibited, ADH secretion will drop. That means that there will be less water consumed and less water will be reabsorbed by the kidneys. And as such, more water will pass out. You will lose more in the form of dilute urine. Now, we can regulate the volume of extracellular fluid entirely exclusive of changes in osmolarity. That's not the only thing that is going to affect this. Blood pressure also is going to have an impact on this. If your blood pressure drops, low volume, this is going to trigger the thirst response. Your body says, hey, we need to increase fluid volume, bring in some more water. So lower blood pressure typically triggers thirst. Also, lower blood pressure means that glomerular pressure in the kidneys is going to drop. There's going to be less pressure from the glomerular capillaries pushing on the renal corpuscle, and as a result, the level of filtration will go down. You will be producing less filtrate and therefore less urine. So that will in turn basically retain water even more. Now, should your blood pressure increase, the body's going to say, all right, blood volume is rising. We need to do something about that. That, in turn, is going to increase the level of glomerular capsular pressure, forcing more fluid into the glomerular capsule, increasing the volume of filtrate, and therefore causing you to pass a larger volume of more dilute urine. This, in turn, will reduce fluid volumes in the body, causing blood pressure and blood volume to drop. So there's a very strong relationship between osmolarity here, overall water volume relative to solutes, and that and your blood pressure as well. A couple different ways we can control this. And again, this is not an either-or situation where it's like, okay, right now blood pressure is going to do this versus osmolarity doing this. All these factors are active at once in a dynamic sort of equilibrium to sustain your homeostasis. But only part of this whole balancing act is the water. The water is the medium in which everything else happens, and the kidneys are regulating water levels. But the kidneys also regulate our levels of electrolytes, because that's the other side of our osmolarity coin, right? It's not just fluid volume, it's electrolyte levels in that fluid. Now, when you hear that word electrolytes, E-L-E-C-T-R-O-L-Y-T-E, electrolytes. Electrolytes are a general term for any charged ions or molecules found in our bodies. They fulfill a wide variety of purposes. And whenever you're very, very thirsty, whenever you're sweating on a hot day, a good reason why something like a sports drink like Gatorade is helpful is because it's not just replenishing water. It's also replenishing crucial electrolytes that you might be sweating out. Now, there are a lot of different electrolytes in our bodies. The most important ones, the ones you're going to hear about the most frequently, are sodium, potassium, chlorine, calcium, and to a lesser extent, magnesium and phosphates. Our bodies take in electrolytes from our food. They are removed via our kidneys, via our skin, sweating out some of them, via our liver, which can actually store certain electrolytes, and in a few cases, via our lungs. Now, assuming that you're in good health, properly fed, the overall electrolyte levels in your body should probably be holding pretty steady. They do not change significantly, except when your body is growing, when you are recovering from injury, or when you are gaining weight. When your body increases mass, electrolyte levels change along with it. When your body is growing, same reason. When your body is repairing damage, again, kind of the same reason. So I wanted to talk to you about a few specific electrolytes. We're not going to talk about every electrolyte that the kidneys regulate, but let's hit some really important ones that you really need to know about to understand kidney function. First off, single most important extracellular electrolyte in your body is sodium. Chemical symbol Na, you all know that one. It's the most important positively charged ion or cation in your body. Now, how much sodium do you need? We usually hear about sodium and say, okay, well, too much sodium is bad for you. As you've all heard me say before, I am sure, whether or not any given thing is good for you or bad for you almost always depends on how much of it you are taking in. And many things that are good for us at low levels are bad for us at high levels, or vice versa. Sodium is not a bad for you thing. Your body requires it. You cannot function properly without it. But you don't need nearly as much as you're probably getting. Average healthy adult human needs approximately 500 milligrams of sodium per day, or about half a gram. Average daily sodium intake in the United States is about 10 to 15 grams. We need half a gram a day. Most of us take in 10 to 15 grams, which means that on average, most Americans are consuming 20 to 30 times as much sodium as they actually require. Believe it or not, you can handle that. That's about the level at which our body can successfully filter out excess sodium. Excess is primary our regulation mechanism for sodium. Mostly it involves removal of excess rather than having to worry about not having enough. In fact, there's good evidence that your body can probably handle as much as 20 times the daily, about 20 grams per day without it having a significant impact on you. Obviously, if your cardiovascular health is poor, you definitely don't want to be taking in that much. And all other things being equal, you don't need that many salts. Find something else to spice your food with. More variety, anyway. Now, kidneys are going to excrete excess sodium. That's the primary mechanism by which we dump excess. Small amount is lost via sweat. You might recall that aldosterone stimulates sodium retention as a mechanism for ensuring that we have enough of it there. ANH or ANP, atrial natriuretic hormone or peptide, is going to stimulate sodium excretion. That is putting more sodium into the urine to lower our levels. And the effects of those two hormones, kind of working counter to one another, are going to regulate our sodium levels pretty well. If aldosterone is present, you're not going to shed a lot of sodium in your urine. If there's not a lot of aldosterone being produced, if you're aldosterone deficient for whatever reason, say a problem with your adrenal glands, then you can shed up to 30 to 40 grams of sodium per day in your urine, at which point you'd probably be in some trouble. Now, sodium has a huge effect on your osmolarity. It's the most important ion for regulating the osmolarity of our bodily fluids. Where sodium goes, water follows. So whenever your body retains sodium, it's going to retain more water. Higher sodium means higher blood volume and higher blood pressure. Likewise, your body sheds sodium, we're going to shed water along with it. Wherever the sodium goes, the water goes with it. And therefore, sodium is of vital importance for maintaining our body's overall fluid levels. Let's talk about what happens if you have too much or too little. The condition of low sodium is called hyponatremia. N-A-T-R-E-M-I-A. Hyponatremia. So that's low sodium levels. Fairly rare. Most of the time, if you have hyponatremia, reasons for that would include severe burns, a lot of vomiting, a lot of diarrhea, excess urination, sometimes as a consequence of poorly regulated diabetes, hyperglycemia. There's a seesaw relationship between blood sugar levels and sodium levels. Elevated blood sugar can reduce sodium levels. And poor diet. Obviously, if you're not taking in sufficient sodium, you're not going to have enough. Although that is, as you've seen, comparatively rare. Should you be hyponatremic, you will experience a sense of lethargy, poor energy levels, neurological confusion and nervousness. Nervous agitation is common with hyponatremia. Seizures can happen, and in severe cases, you can go into a coma. How about hypernatremia? Hypernatremia. Hypernatremia. That's excessive sodium. That's more of an issue. This is usually caused by excessive dietary intake. Most of the time, if you've got elevated sodium levels, it's just because you took in too much. Now, things that you will get out of this. Also, a lot of water loss. A large amount of water loss will also concentrate available sodium and can lead to you becoming hypernatremic. If aldosterone is overactive, hypersecretion of aldosterone, which can happen because of adrenal tumors, that can also lead to excessive sodium retention. But most of the time it's dietary. If you have high sodium levels, that can cause persistent thirst, dry mucous membranes, fever, bounding pulse, elevated blood pressure, and in severe cases, you can end up with edema as your body retains too much water in the extracellular compartments, along with that sodium, remember. And in very severe cases, you can go into convulsions and eventually technically die, although deaths from hypernatremia are vanishingly rare. Now, we can't talk sodium without talking chlorine. Chlorine is another really important substance, so we normally take them in at the same time because we usually get most of our sodium from salt, sodium chloride, NaCl. So usually when you take in sodium, chlorine is coming along with it. Now, chlorine is the primary anion in our extracellular fluid. Sodium is a cation, positively charged. Chlorine is an anion. It's the main negatively charged ion found in our bodily fluids. It is attracted to sodium, calcium, and potassium. And as a result, the mechanisms that regulate the three of those also regulate chlorine by default. There are no special regulatory mechanisms for chlorine, most strongly affected by sodium. Chlorine deficiency is so vanishingly rare that there is not even a clinical term for it that I am aware of. I couldn't begin to tell you what happens in that instance. Likewise, excessive chlorine, unless it's not attached to excessive sodium, doesn't have any separate effects apart from excessive sodium. If you're getting too much chlorine without excessive sodium, high levels of chlorine gas, I'm sure you are aware, can be lethal. Chlorine gas was at one time used as a weapon of war during World War I, before the banning of chemical weapons. Now, maintaining chlorine levels is vital because, again, this is the primary anion. It's the primary negatively charged ion, and therefore you need it to balance out the positively charged ions. This helps our body to maintain its overall electroneutral balance, to make sure our bodily fluids remain electrochemically neutral, because excessive positive or negative charge could interfere with a lot of different reactions, from how our nerves transmit signals to how your muscles contract. So chlorine is tied in with all of that, basically to counteract the positive charge of other ions. We also have a high concentration of chlorine in your stomach. You probably are aware that hydrochloric acid, HCl, is a significant part of gastric juice. In the absence of that, digesting your food properly would not go very well. All right, how about potassium? Also hard to talk about sodium without talking about potassium as well. Potassium is going to be passing freely through the filtration membrane in the renal corpuscle. It's typically reabsorbed by the body in the proximal convoluted tubule, and any excess is then secreted into the distal convoluted tubule. Now, you'll find that potassium is regulated pretty much by the same mechanisms as regulated sodium. That you're going to find that sodium-potassium pump is a big factor here. You need both of those things to exist in a level of balance. Aldosterone increases potassium levels at the same time as it increases sodium levels. Things that can lead to increased concentration of potassium include tissue damage, circulatory shock, and dehydration. Now, should you have insufficient potassium? Hypokalemia, Hypokalemia. Hypokalemia, that is potassium deficiency. Most commonly a result of dietary deficiency, not taking in enough to begin with, and odds are pretty good you're potassium deficient, at least a little bit. It's one of the most common nutritional deficiencies in the United States. You want to do something about it? Eat a banana. One banana a day contains about as much potassium as your body needs to meet its daily allowance. But in terms of what you get out of this, hypokalemia can be caused by insufficient dietary intake. It can also be caused as a result of excessive renal loss. If you're shedding too much through the urine, then that's a problem. You can also end up with hypokalemia as a result of insulin administration. One of the side effects of taking external insulin supplements is that it tends to reduce circulatory potassium levels. Things you will get from hypokalemia: skeletal muscle weakness, poor response in your muscles, loss of muscle tone, and in severe cases, bradycardia, that is impaired heart rate, and heart blocks. Now, hyperkalemia, 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 as you can probably guess, is excess potassium. Fairly rare. Normally happens as a result of reduced renal excretion. That is, the kidneys are not adequately eliminating potassium because of kidney disease or other problems. Hyperkalemia will cause restlessness, irritability, nervous agitation, intestinal cramping and diarrhea, and over the long haul, it will lead to muscular weakness and eventually paralysis if you don't have enough. Remember, you need potassium to stimulate muscular contraction. Inadequate potassium is going to lead to muscular paralysis after a while. Usually doesn't get to that point. All right, and last ion I wanted to tell you all about, good old calcium. Let's talk about our calcium for a minute. Now, calcium is managed not only by your kidneys, but also by your intestinal tract, controlling the absorption of calcium, and by your skeleton. You might recall that our skeletons are our body's primary mineral reservoirs, and calcium is the mineral that we store in the greatest concentrations in our skeletons. So, excess calcium can be stored in the skeleton to a certain extent. When the body is low on calcium, it can exchange calcium with bone and release a little bit as a reserve. At any given time, about 99% of the total calcium in your body is stored in bone. Most regulation of calcium involves depositing calcium into bone to deal with excess, or releasing it from bone to deal with insufficiencies. The primary regulator of our calcium levels is going to be parathyroid hormone, or PTH. Remember that from our endocrine system. The entire job of parathyroid hormone is to regulate extracellular calcium levels. When you increase your levels of PTH, it will cause an increase in extracellular calcium and reabsorption of calcium by the kidneys from the filtrates. You will also find that parathyroid hormone increases vitamin D uptake from the small intestine, since you might recall vitamin D is intimately involved with calcium regulation as well. Now we have another hormone called calcitonin, C-A-L-C-I-T-O-N-I-N. Calcitonin has the effect of reducing blood calcium levels by lowering the rate of calcium release from bone. Calcitonin is a calcium-conserving hormone, prevents our bodies from releasing too much. So, what happens if your calcium gets out of balance, folks? Hypocalcemia, H-Y-P-O-C-A-L-C-E-M-I-A. Hypocalcemia is low calcium. Hypocalcemia is usually due to dietary deficiency. You're not taking in enough calcium in your diet. Maybe you're not getting dairy products or whatever. But it can also happen as a result of low vitamin D levels. Vitamin D is needed for the process of absorbing calcium. So if you're not getting enough sunlight, vitamin D is low. As a result, you can end up calcium deficient because of that. If your parathyroid hormone is not at adequate levels, if secretion of parathyroid hormone is reduced, that can be a problem. Sometimes parathyroid glands get damaged as a result of thyroid surgeries, and that can result in the loss of parathyroid glands or inadequate action of them. But if their activity is low, then you may not be storing enough calcium in your body. Or you may not have enough circulating in your body, I should say. And finally, bone tumors. If you have a bone cancer, soaking up more calcium as that bone tumor grows can lower circulatory calcium levels. Effects of hypocalcemia include confusion, difficulty concentrating, muscle cramps and spasms. In severe cases, muscular convulsions, tetany of the muscle, and in extremis, death by suffocation, whenever the muscles cramp up and cannot relax. Although it's exceedingly rare to die from inadequate calcium. How about hypercalcemia? Hypercalcemia. Hypercalcemia, excessive extracellular calcium. That is often a result of excess PTH or excess vitamin D. Excess vitamin D is vanishingly rare, but excess PTH can happen because of parathyroid tumors. You will find that hypercalcemia will cause fatigue, muscular weakness, feeling of lethargy and low energy, can result in nausea, can result in constipation, and can result in coma and death if it's allowed to persist for too long. Also seems to be a factor in kidney stones, but we'll talk about that when we talk about kidney pathologies in a few minutes. So last but not least, to finish this off, we've dealt with most of the key aspects of urinary system function at this point, including its various chemical regulatory functions. Let's tie this off by taking a look at some select kidney pathologies. Now, as you've no doubt gathered, there's a strong relationship between proper kidney function and a lot of other bodily systems. You've seen where things like diabetes or circulatory issues can have a direct impact on the kidneys by changing the pressure or the chemical environment under which they work. But I want to talk about a few kidney-specific issues. First off, let's deal with the normal consequences of aging before we get into pathology. Your kidneys are going to lose functionality as you get older. This is inevitable. Even if you do all the right things health-wise, your kidneys when you're older are not going to be as good as they were when you were younger. In fact, by the time you are in your mid to late 20s, your kidneys have already begun to shrink. Only a little. That shrinkage, however, will be noticeable by the time you're in your 50s, and it will gradually continue until your death. Now, as the kidneys shrink, arteries within them become twisted, kinked, and glomeruli get pinched off, and functional glomeruli are lost. As a result, you have fewer and fewer active nephrons the older you get. If you live to be in your 80s, you will be down to about 60% of the nephrons that you had at the peak of your health. You'll lose about 40% by the time you're in your 80s. That means that your ability to concentrate urine will gradually decline as you get older. This means that older people are at greater risk of dehydration and have a reduced ability to eliminate metabolites. What that means is that urea, creatine, uric acid, and a variety of toxins can all build up in the body more effectively. That older folks are more prone to the toxic buildup of metabolites than younger and healthier people. Now, also as you get older, your body's sensitivity to some of the regulatory hormones goes down. You end up having reduced sensitivity to their effects, which means in particular ADH and aldosterone are no longer as effective the older you get. And therefore, they're not able to as effectively stimulate the kidney's ability to regulate your blood pressure. Your kidney's ability to make vitamin D declines as you get older as the kidneys receive less and less effective blood flow. Reduced vitamin D means, among other things, a greater propensity for calcium deficiency disorders, like, for example, osteoporosis. This is a big part of why your body's ability to absorb calcium declines with age, because the kidneys are no longer as good at making vitamin D. Bone fractures, of course, become more likely as you get older because your body's not storing calcium as efficiently, and all the problems associated with calcium deficiency that I mentioned previously. Now, all of this doesn't sound terribly good. All of this, however, is part of normal functionality. And for the most part, you're not going to have that much trouble. Because even though I just mentioned a whole bunch of problems that come with the kidneys happening as you age, this is all still with perfectly functional kidneys. You have a lot of spare capacity. You probably all know that you can get away with having one kidney. Many of you might know somebody who donated a kidney to somebody who was in need of a transplant or what have you. So yeah, you can absolutely get away with one kidney. You may not know that you only need 1/3 of one kidney. Each kidney has about 3 times as much capacity as is needed for the entire body's filtration. So if you have 1/3 of one functioning kidney, or rather I should say 1/3 of one kidney functioning, you will probably be okay. You will probably not be experiencing any signs of kidney failure. That's good. That means you can suffer a fair bit of damage to the kidneys without having any trouble. You've got a lot of spare capacity. This also, however, means that by the time you notice kidney problems, a lot of times a lot of damage has already been done, and there's not that much more you can do about it. So in healthy individuals, the normal loss of kidney functionality with age is not a big deal. However, if you have other risk factors, such as hardening of the arteries, hypertension, diabetes, COPD, or other heart problems, at that point you can't spare as much, and damage to the kidneys is going to be more damaging to you. All right, But now let's talk about a few select kidney-specific pathologies. Let's talk about kidney stones. Kidney stones are a problem that you probably have all known somebody who had them. By the numbers, you might very well have some right now, because about 1% of people at any given time have kidney stones. You may not even know it because most of the time they are actually asymptomatic. Now, kidney stones are small mineral accretions, typically found in the renal pelvis. Some of them are smooth on their surface, some of them are jagged. Jagged ones are the ones more likely to cause us an issue. Now, your average kidney stone is pretty tiny. They're usually about 2 to 3 millimeters in diameter. They're primarily made out of calcium minerals, calcium phosphates, and calcium oxalates, OXYLATE, are the two primary components, but you will get other things in there occasionally as well. Now, the cause of kidney stones is not always clear. We know that excessive calcium, hypercalcemia, can contribute. It does seem that they happen more commonly in people with recurrent kidney infections, but we don't know if that's because something about recurrent kidney infections makes you more likely to get stones, or whether the propensity to get stones makes you more likely to have kidney infections. We know there's a correlation. We don't know which way the causation goes. Also, people who have gout. If you have gout, kidney stones are a frequent complication of that. So if you've got them and they're asymptomatic, no big deal. They can just be there. The problem arises when the kidney stone enters a ureter and can cause irritation or blockage. Obviously, this can lead to intense pain. It can lead to epithelial bleeding. A lot of times we know a kidney stone has gotten serious when blood begins turning up in your urine. This can also lead to a greater propensity for kidney infections because of the damage being done there. And of course, if the ureter is blocked and we have a limited ability to remove urine from the kidneys, that becomes a very serious issue. Now, kidney stones are actually fairly easy to treat. At one time, surgery was necessary. And for really big kidney stones, might still be. But for small kidney stones, we can usually resolve the issue non-surgically with external laser treatments or with lithotripsy, Lithotrispy. Lithotripsy is basically using sound waves moved through your abdomen to shatter the kidney stone. Now, the real fun part, of course, comes after the kidney stone has been shattered. You can shatter them with external sonic or laser treatments without having to cut into you. Great. Now you have to pass it. Passing a kidney stone is excruciatingly painful. In fact, it is technically the most painful experience a human body can have. There is, in terms of the actual electrical activity we can see in the brain, kidney stone passage is more painful than childbirth. And it's not a fun experience to have to go through. Hopefully you never will. But sometimes entire tiny kidney stones can pass, but usually we're dealing with the fragments from lithotripsy or what have you, in which case the pain is extraordinarily intense. And this is one case where, although women are much more prone to kidney infections than men, men have a much worse time with kidney stones because that longer urethra means it has to travel down a much longer passageway on its very painful way out. All right, so let's deal with the big one. Let's deal with renal insufficiency. Renal insufficiency is better known as kidney failure. This is a state in which the kidneys cannot maintain homeostasis. There are a lot of possible causes. Poisoning can actually cause this. A number of toxins can actually damage the kidneys and lead to kidney failure. A transfusion reaction from having the wrong type of blood donated can cause kidney failure. Anything that releases large amounts of bilirubin or proteins into the bloodstream all at once can lead to kidney failure. Circulatory problems, persistent pressure on the kidneys from high blood pressure or from the complications of diabetes mellitus can lead to kidney failure. A lot of things can happen here. Now, kidney failure can be acute or chronic. And really, either way, it involves the destruction of nephrons, the loss of functional nephrons, and therefore the inability to adequately filter urine. Now, acute kidney failure is a temporary condition. It is a temporary shutdown of the kidneys. This can sometimes happen as a consequence of infection, a consequence of trauma, a loss of blood flow due to thrombosis or hemorrhage. These are all things that can temporarily lead to kidney failure. Often those are reversible. A lot of times acute kidney failure will resolve within a few days if you are able to adequately repair whatever caused the organ. In a healthy kidney, it should be pointed out that a certain amount of glomerular regeneration is actually possible, and therefore acute kidney failure can be recovered from. Chronic kidney failure is a different animal. Chronic kidney failure is the long-term, progressive, and irreversible loss of kidney function, the destruction of nephrons from which you cannot recover. Possible reasons for this: hypertension, chronic or repetitive kidney infections. Enough kidney infections can over time lead to kidney failure. Physical trauma to the kidney, actual injury to the kidney. Prolonged ischemia or hypoxia, that is deprivation of oxygen to the kidney. Heavy metal poisoning, hardening of the arteries. All these things can contribute to kidney failure. And there's an autoimmune disease called glomerulonephritis. Glomerulonephritis. There's a good Scrabble word for you. Would it even fit on the board? I'm not sure. Okay. Glomerulonephritis is an autoimmune disease in which the body attacks its own glomeruli. We don't know why it happens. So, nephrons can regenerate from short-term issues. Acute kidney failure damages a nephron. They're actually pretty good at regrowing. So, temporary blockage of tubules by excess proteins, trauma that you can heal from. These are things you can recover from. And existing nephrons, we find, this is cool, that whenever some portion of the kidney is damaged and healing, remaining nephrons will experience hypertrophy, Hypertrophy. Hypertrophy is basically your overgrowth of any structure. Excessive growth in any structure is hypertrophy. And oh, hello. This is Eris. I think you guys have met her before. She's here to help me talk about kidney failure. All right, so you can recover from these short-term problems. Long-term problems, not so much. So what happens in the long term as a result of kidney failure? Like I said, you can lose an awful lot of kidney function before you even know there's a problem. In fact, typically you will not begin to experience symptoms of renal insufficiency until 75% of your nephrons are gone, by which time, honestly, recovery can be really hard. What happens as a result of kidney failure? You can end up with anemia. Remember, kidneys are making erythropoietin. They're involved in your red blood cell production. Destroy a lot of kidney tissue, you're not going to make as much erythropoietin. You're not going to make as many red blood cells. And you'll have the cascade of effects that come from that. Other things that will happen, you will experience blood acidosis because of the buildup of acidic metabolites in the bloodstream. And you will experience azotemia. That's the most diagnostic clinical feature, azotemia, which is elevated levels of blood urea. Now, if the problem cannot be stopped, if it has been a progressive issue, we cannot deal with the underlying problem. Of course, just like so many organs in the body, once part of the thing begins to fail, it puts more strain on the rest. If you can successfully arrest the problem, you may be able to prevent further damage, but by the time it gets to this point, a lot of times there's very little you can do, and it's just a matter of forestalling the inevitable. If you lose 90% of kidney function, you will begin to experience uremia, U-R-E-M-I-A. That is toxicity from the accumulation of metabolites. In uremia, you will experience a number of symptoms: diarrhea, vomiting, cardiac arrhythmias as a result of electrolytes interfering with the normal sinus rhythm of the heart, dyspnea, D-Y-S-P-N-E-A, if you don't know that term, that is labored breathing. In late stages, you can become extremely neurologically distressed. You can basically lose focus and concentration altogether. A lot of folks who are in late stage kidney failure are not terribly aware of what's going on around them. At the end stages, you often go into convulsions and slip into a coma. Death can follow within a couple of days. Uremia, once it begins to set in, you don't last long. So what do? Kidney failure? The long-term solution, really only one option, and that's kidney transplant. Give you a new kidney. You're probably all aware that kidneys are a difficult organ to match. It's more than just blood type. You need to match a number of different cell surface identity markers to have any chance of the kidney being accepted by your body whatsoever. So finding a kidney that is a good genetic match for you can be exceedingly difficult. If you can get one from a blood relative, that's the easiest possibility of making one work. So, your sister or your mother or your cousin, needs a kidney. You as a blood relative are the likeliest person to be able to provide one that will work for it. Now, you can get it from a stranger if you can get the right match. Now, there's a thing that actually happens sometimes. This is a really cool thing that was developed here in Pittsburgh. The idea of a so-called kidney ring. And what they'll do is they'll be like, okay, so Bob here needs a kidney. And he's a match for Jane. Jane has a kidney that would work for Bob. But here's the thing, that Jane's brother needs a kidney, and Jane's brother isn't a good match for her for whatever reason, but this guy knows somebody else who needs a kidney that would be a good match for Jane. And basically you can do this sort of like loop thing where it's like, okay, I give a kidney to you, you give a kid or to this person, I will give a kidney to that person, and then another person will give a kidney to me. That you'll work out these long exchanges where people basically agree, okay, I'm going to give up a kidney for someone. It's not necessarily my relative, but in return, somebody else's relative is going to give up a kidney for mine that we are a match for. Actually, the biggest kidney ring ever pulled off happened in Pittsburgh about 10 years ago. 16 people were involved. And it involved a marathon series of kidney transplantation surgeries. They had to bring in kidney transplant surgeons from all over the world for it. It was kind of a big deal. Now, of course, with a kidney transplant come all the complications long-term of transplantation, including the possibility of organ rejection, but it does allow you the possibility of resuming normal functionality, and at least a chance to try to recover from the underlying issues that led to it in the first place. We are working on the possibility of 3D printing kidneys. Right now, the idea is if we can recover cells from your kidneys, cells that are a genetic match for you, culture them, load them into cartridges, we can basically 3D print a kidney for you, or possibly grow a kidney on a frame using nutrient-rich solutions to keep the cells sustained while it's growing. We're already doing some very successful early-stage experiments with that, and so we're hopeful that in the not-too-distant future, we may be able to realistically build new kidneys that are a genetic match for the person who would be receiving them. Not quite there yet, but it's in the offing, and more likely than not, you're going to see the first 3D printed kidney in the next 10 years. But obviously, finding a kidney for you right now, you got to get on waiting lists, and once you're in kidney failure, once you're in uremia, you don't have long. So how do we keep you going until the kidney can arrive? You probably all know the answer to this, a technology called dialysis. Actually, the full name is hemodialysis. Hemodialysis. Hemodialysis is basically the artificial filtration of your blood. Rather than having a kidney do it, we hook you up to a machine that does it for you. The easiest way to do this is with a stationary dialysis machine, which is basically a big old artificial kidney. We plug you into it, we let it filter your blood, and you're good to go. Now, it's not as easy as it sounds. Dialysis treatments come with a lot of possibilities. We're having to stick you all the time with big needles and run all the blood in your body through a machine. This leads to the risk of infections, leads to the risk of thrombosis from blood clots from sticking you all the time. Gives you the realistic risk of internal bleeding and all the problems that can come with that. Furthermore, standard hemodialysis is a pretty damaging thing to most people's lifestyle in that you typically need 3 sessions a week hooked up to the machine for 4 to 8 hours at a time. So needless to say, this is not a thing that is a casual treatment. You basically can't really do a whole lot while you're under dialysis just because of the frequency needed of the treatments. And this is all assuming, of course, that the underlying problem isn't getting worse. Now, we got a better technology nowadays. A few years back, we invented a thing called CAPD, which stands for Continuous Ambulatory Peritoneal Dialysis. It's basically a home dialysis machine. It's ambulatory. It's a portable device. It does not require you going to a stationary machine. You can do it at home. You can take it with you when you go places. It's, however, less efficient at waste removal, at least with the current state of technology. We're working on improving it, but right now it is not as good as a stationary dialysis machine. Furthermore, it tends to lead to more infections. Unless you're being overseen by a trained medical professional helping you use it in your home, then odds are pretty good that you're doing it yourself. The risk of infection goes up considerably. And you're also not doing it in the sterile environment of your dialysis center that's presumably protected better against possible infections that would get in. So, a couple of examples of select kidney pathologies for you. All right, and that, folks, wraps up our look at the urinary system. From here, we will be moving on to digestion. I will talk to you all soon. Hope you all have a great night. Hey, folks. All right, so picking up where we left off, we've taken a look at some key electrolytes. But one last really important bit of kidney chemistry involves the regulation of pH. Now, naturally, as we are taking a look at all of these different ions present in your body's fluids, inevitably, pH is going to change up and down a little bit. And you'll find that most areas of the human body, you already know this, are highly sensitive to changes in the pH of their fluids, that most of our crucial enzymes and other chemical compounds require a very specific pH environment in order to work properly. Taking them out of it, not going to work terribly well. For most fluids in our body, the range is not even all that big. Consider that you run into problems with your blood if the pH is anywhere below 7.35 and higher than 7.45. We have a very narrow window in which the chemistry is going to work optimally. So, how do we stabilize blood pH? We use a series of molecules called buffers to do that. If you've taken a chemistry class, you already know what a buffer is. A buffer is anything that we use to regulate changes in pH, and our body relies on a number of buffer systems in order to effectively manage its pH. All of these buffer systems basically work the same way. They involve the selective absorption or release of hydrogen ions from a pair of molecules. Remember that whenever a solution is acidic, that means it has a higher concentration of hydrogen than it does hydroxide. And when a solution is alkaline or basic, that means it has a higher concentration of hydroxide than hydrogen. So we can effectively manage the pH of any solution by adding or removing hydrogen ions. You release hydrogen ions into the solution, its pH will drop. Take them up, have them get absorbed by something else, take them out of solution, the pH will rise. So all of our biological buffering systems involve a pair of molecules, one of which is a negatively charged ion able to receive one more hydrogen atom, and one of which is a molecule with no space for that. So what we do here is that our buffers will selectively release or absorb that hydrogen as needed. So feedback loop whereby if the pH of the bodily system in question falls too low, then the ionized form of the buffer will take up hydrogen in order to raise it. If, on the other hand, the pH of the solution rises too high, the buffer molecule will release hydrogen in order to lower it. So it actually changes back and forth between the two forms, which differ from one another on the basis of one hydrogen ion. You might already know from previous discussion or previous reading the buffering system used in human blood. The most important buffering system in our bodies involves carbonic acid and bicarbonate. We call it, in fact, the carbonic acid / bicarbonate buffer system. And bicarbonate, BICARBONATE. So carbonic acid / bicarbonate buffer system. Those molecules, just for your reference here real quick, I'm going to sketch a quick little drawing for you, if I can find my pen, which is somewhere in my workstation. It's the problem with having cats in your workstation. All right, so carbonic acid has the chemical formula H2CO3. Bicarbonate is HCO3. Like so. Now you can see the difference between these two molecules is one hydrogen atom. I should actually be putting the proper ionic charge on HCO3, like so. So if my blood becomes too acidic, then bicarbonates is going to soak up hydrogen ions. You can see if you add a hydrogen ion to that molecule, it turns into carbonic acid, taking that hydrogen ion out of solution and therefore raising the pH. If the blood's pH rises too high, carbonic acid will release hydrogen ions into the bloodstream, lowering the pH and turning the carbonic acid into bicarbonates. That's the basic mechanism by which every buffering system our bodies use functions. Now, in some intracellular compartments, there are protein-based buffering systems, but for the most part, it's smaller molecules like that. Within the kidney filtrate itself, pH is regulated by two buffering systems. There is a phosphate buffer system, which uses H2PO4 and HPO4 as its buffering molecules. And there is an ammonia buffering system, which relies on NH4 and NH3. And that's how we manage pH balance in the kidneys themselves. Now, part of the function of all this is that respiratory system helps to regulate this by introducing carbon dioxide. Carbon dioxide then combines with water in the bloodstream to form carbonic acid. It's a pretty simple equation. CO2 plus H2O yields H2CO3. Water plus carbon dioxide, carbonic acid. It's a balanced equation. So that is an important thing that we have going on here. But as for the rest, where's the role of the kidneys in this? The kidneys regulate pH by recovering bicarbonate from the filtrates. They are going to recapture bicarbonate that otherwise would be filtered out in the blood. They also add new bicarbonate to the blood by producing it in their collecting ducts. The collecting ducts of the kidneys actually make bicarbonate ions, which are then collected by the vasa recta and introduced into circulation. So the kidneys play a direct role in this buffering system by providing bicarbonates, just as the respiratory system plays a direct role by providing carbon dioxide to make carbonic acid. Now, while we're talking about this, consequences of these being out of balance. High fluid pH is alkalosis, ALKALOSIS. So anytime you've got overly high pH in any bodily fluid, that is alkalosis. If we're dealing with blood alkalosis, the most significant problem, we're going to have symptoms including a hyperexcitable nervous system, nervous agitation, muscular spasms, and in extremis, you can end up with tetany, convulsions, and eventually death. On the other hand, let's suppose that you have blood acidosis, ACIDOSIS. Blood pH is too low. If that's the case, the central nervous system will be depressed in its function, leading to slower responses, disorientation, and eventually putting you into a coma and death. What can cause these things? Alkalosis can result from insufficient oxygen intake. Low atmospheric pressure of oxygen can be an issue. It could be reduced levels of CO2 in the extracellular fluid, or severe vomiting, which lowers the acid content of your body, can also result in alkalosis. Acidosis is caused by a couple different things. High levels of carbon dioxide in your bodily fluids, making it too acidic. A lot of drugs and toxins cause acidity in too high of concentrations. That's also the case for some alkaline drugs. Inadequate oxygen perfusion often leads to acidosis. The accumulation of fatty acids or ketones in the bloodstream from a body relying too much on fat metabolism. This is not a very good reason, a good time to say that an Atkins kind of diet or a keto kind of diet, generally not a good idea. You're basically putting your body through the strain that you would normally experience from untreated diabetes for relatively little benefit. Speaking of, untreated diabetes can lead to acidosis. Ketoacidosis is the pervasive problem that leads to diabetic shock. And finally, you can also end up with acidosis as a result of bacterial infection. It's worth pointing out at this point, folks, that acid-base balance in our bodies is really, really important to overall chemical function. Most of your body's enzymes have a very narrow range of optimal pH in which they work okay. Throw that out of whack, the protein stops functioning, and you are in trouble really quickly. Most of the things that kill us, most of the time when you die of something, at the end of the day, we could really trace the cause of death to a failure of homeostasis due to acidosis or alkalosis. What happens to you when you die of diabetic shock? Blood acidosis is what killed you. What happens to you when you die of septic shock from a bacterial infection? Once again, blood acidosis. A lot of poisonings, blood alkalosis. Suffocation, acidosis. These are all really, at the end of the day, about failure to maintain the chemical environment needed to sustain life. All right, so that is kind of our